Thank you. And I must thanks to Dr. P.K. Hazar and the organizers for giving me the opportunity to be here. And this is Bangladesh session. I'm Professor S. Mustafa Zaman, President of Bangladesh Cardiovascular Research Foundation and Professor of Bangabandhu Sheikh Mujib Medical University. Nice to meet you all. And though I used to come Calcutta many times, but this is actually second home. So I always enjoy just like my home country. So I'll present how to deal with non-true Lettman bifurcation. And every day we're facing this type of problem and in our cath lab. So this is very important, true and non-true bifurcation, though still a gray zone in bifurcation. And still now we're watching the live case also and a lot of presentation by your young cardiologist in the morning I've seen. And this is the area is we call the different animal. So a lot of factors associated with the late main osteal LAD and osteal LCX. So this is a gray zone and more prone to atherosclerosis. Some area you already have seen, and so it's very difficult and case to case variation uh, when we treat in our cath lab every patient. So a lot of evaluation, you can see the guidelines. So ultimately, ESC guidelines and SCCHA guideline is SCA guideline. The, from 2005 to gradually it is increasing, and ultimately ESC guideline class 1 indication very late, and CINTA score is less than 22. PCI is recommended patients with late main disease. And in 2021 also SCC and HA guideline also class 1 indication, but before that it was not the class 1 indication. And what is true and non-true? And we have the Medina classification. I must thanks to Alfonso Medina. And you will see the 111, 110, 101, 011, 100, 010, and 001. All the 7 bifurcation lesion and proximal distal lesion and with side branch we always face. And the 3 lesion actually true among the 7 types 011, 111, and 0101. So you always most of the time true bifurcation lesion we are saying, but sometimes non-true bifurcation lesion we have faced, and how to deal this bifurcation lesion. I will share our knowledge, but I know a lot of senior cardiologists in cardiology here will share our knowledge, especially kissing balloon inflation. Is it mandatory or not? Where will do kissing balloon inflation or not? And a lot of issue we'll discuss in the short time. The rest are non-true bifurcation. Already I mentioned that other than 3, all are non-true. So this is also creates problem when we treat this patient. You'll see the non-true. I'll take time because all the CD will not come at a time. So all are non-true. So some we will see the CT also LAD total occlusion from ostium of the disease. So with how will deal this patient? You will see the patient only late main disease, but the LAD and LCX also good. And here also you'll see the only osteal LAD disease. So here also only LCX. So lot of things that we can share. So real world scenario of non-true latent bifurcation, some practical issues. Again, I mentioned that is so in general, whatever true or non-true, professional philosophy is the call of the present time. But always we can't say that one stent is best, better than two stent. So sometimes 2 stent needed, sometimes 1 stent needed. So we'll see the RCT among the 2 stent and the 1 stent, and the provisional stenting versus systematic double stenting in late main bifurcation lesion, and the MACE, all-cause mortality, CV mortality, MI, stent thrombosis, target lesion, revascularization. There's a comparison. You'll see the 19 here, systematic double stenting and provisional stenting, 16% MACE. All-cause mortality is 9.5%, provisional 9.3, CV mortality 4.6, 5.8, MI 8.3, this is 8.6. And the stent thrombosis 2.3% and 2.8%. Here is some greater in comparison, target lesion revascularization 11.1% versus 7.7% in provisional stenting. So very important slide also this is, and you'll see that that angle very important. One is the angle between late main to LCX, angle between LED to LCX, and angle LED to late main. All the angle is very important when we decide which strategy we should follow. And the assigned sidebands is very important because there's maybe disparity of the LED size and LCX size also. And so there's maybe changes of the proximal and distal segment also. So it is very, very important. So EBC 16, they mentioned the assigned side branch. That means changes of the distal vessel and changes of the side branch. This is depends on anatomical and origin of the distal vessel and side vessel also. And when we this may called assigned side branch. And I'll not go elaborately because the live session is going on. So we'll discuss live session also. So IVAS is very important because the strategical follow-up and which strategy and how to manage this patient. IVAS is very, very important in here. And though it's not the class 1 indication, only 40% we can do IVAS use. And you'll see the IVAS, how can help us in taking decision in this scenario. Let's see 001, 100, 110, 010, 101 cases. The scenario 45 years and height of the angina, and some scenario like diabetes mellitus, dyslipidemia, smoker, ECG, you'll see echo, everything. So CAG findings was here. You'll see the 100 and is it CABG or PCI? I don't know how many actually cardiologists here they will say CABG or PCI, and what should be the strategy. So I'm going to next slide. So does IVAS assessment is mandatory, and because maybe it's simple, but not always simple. Always it is very important to take the decision, single stent, and when you go crossover stenting, let me into LED, that may be a chance of osteal stone actually create problem on the osteal LCX also. So may I go let me into LCX? So it is very important. So that may IVAS may help also in this take decision. So we will see the L6 to LED where both wires should be both vessels should be wired. Then we'll take the decision. This is the thumb rule. Which one will be the assigned side branch? This is very important. In EBC 16 they told me, and this is a big dilemma. Big dilemma. Maybe let me into LED or let me into LCX. Can you raise your hand? Which let me into LED? How many? Let me LED, and let me into other, let me into LCX. So there we will see that the diameter is LED and the LCX is a little different. IVAS will help us, and then we'll, but both vessels should be wired, and IVAS should actually LCX to LED is 2.75 and the LCX is 3.5. So let me into LCX because diameter, again, you mentioned that the disparity of the diameter of the LCX LED and the changes of the distal vessel and side branch, and this is called assigned side branch in 16 EBC line. So it's the biggest question now, final KBI or not to kiss. So again, maybe a dilemma also, somebody told kissing balloon inflation needed or not. And if actually eventual kissing prevents fenestrial restenosis if we do KBI, and so somebody will take the will do the kissing balloon inflation, but not necessarily somebody, but because the Nordic 3 did not suffer the routine KBI both in true and non-true bifurcation. And Corbis 3, similar outcomes. Even EBC mandated KBI even in provisional standing by protocol. So it is also big dilemma also. Without KBI, you will see this also good result also. So let's see a case of 0-1-0 Lettman bifurcation lesion. This create problem in the cath lab. How will overcome this scenario? Especially we'll do the only LED, but all distal Lettman may be involved. And when I put the stent Lettman to LED, what should, so lot of question maybe what should be the, so this how will overcome plan again. So a real world scenario simple, but not a simple again I mentioned that. So I was again help us to take the decision. So crossover stenting prevention studies is the plan and how we'll overcome this situation. And again, I was help us. I'll take little time because a live session is going on. So you'll see the Lettman has a mild plaque extension, LED diameter looks 3 to 3.5 millimeter, and LCX and ramus osteum are disease free. So you'll see Lettman to LED and pot also. So now the trickiest question for this case is that SBs, even though TIMI 3 flow was there, and KBI again important to open the jail stars in the SB. So this question is going on in the cath lab every time we are facing this type of problem. So report also done. Post-port IVAS also done. And final picture. Controversy 0-1-0 and strategy should be maybe different. Operators discussion and hard team may be sometimes needed, and true carrier shifting, plaque shifting, to be or not to be KBI. Again, this dilemma. Let's see the another 0-1-0 Lettman bifurcation, this time with CTO LED. Already I have shown the first picture, this CD, and 0-1-0 Lettman bifurcation with CTO LED from this is ostium. The scenario is 65 years, male, diabetes mellitus, hypertension, prior MI, anterior 2 years back with unstable angina, LVF 50%. You'll see where is the LED ostium, CTO proximal cap is nowhere, and dual injection also given. So this is create another dilemma. And two challenges: open the CTO and handle the 0-1-0 Lettman lesion. I was again guided us. So could you open the CTO? What to do for 0-1-0 Lettman lesion? I was have no question about the role, and only osteal LED stenting without involving Lettman disease possible or not. Again, angle is important because again, first the previous slide already have discussed in this regard. We'll see the final peak. Are you happy with the scenario? So yes, what about the most controversial 0-0-1 lesion in Lettman bifurcation? Non-diabetic, normotensive, young, 9-year-old female with non-STMI. Angiographically, Lettman looks okay, though mild plaques are there. Basically, this create a lot of problem in the cath lab. How should we overcome? On the morning, I've seen the previous one presenter actually present only osteal LCX. This type of lesion. Somebody told the only DCB. Somebody tell just forget about the lesion, about the ischemia and risk stratification. A lot of things, clinical judgment also. So again, if you see the 70 to 80% stenosis in the osteal LCX, and may have a higher diameter discrepancy with the Lettman with the other two vessel. Angiographic angulation is very important. Osteal miss or floating. So there's a lot of question and lot of answer also, and lot of plan also you will see. So apparently 001 lesion, osteolysis lesion is a deep pain for an interventional cardiologist. I'm quite telling this repeatedly. So I was again. So vessel bed preparation, important. We'll see. Little bother for KBR report as I was looks good. And this is hard talk is that is if L6 were a smaller caliber with acute angle with LADU, where ostial positioning of a stent is not feasible, what would be the management for that pathogenic 001 late main bifurcation lesion? Some answers are evolving, and you will see the contemporary management of isolated osteal sideburns disease and evidence-based approach to Medina 001 bifurcations. And treatment of corona bifurcation lesions, part 1, implanting is the first stent in the provisional pathway. The 16th expert consensus document in European by EBC. Obviously not yet to be class 1 and 001, especially for non-interventional management. Again, I mentioned maybe the interventional management, balloon angioplasty and leave nothing behind. So flush osteal technique, bailout to a stent technique, inverted provisional technique, a lot of decision may be taken by the interventional cardiologist in the cath lab, and take a message, non-true and true late main bifurcation lesion to be judged by the IVAS, POT and KBI to do when SB looks suspicious. Future of DCB in bifurcation lesions needs more data. And though I mentioned case-to-case variation may be needed, and non-true left main bifurcation may turn into bailout to stent study, or it may remain well with GDMT. Thank you all for question sharing.